haven't made it on time, they're not coming.
Great.
Okay.
All right, well, so today's fellows meeting, Zion's gonna kind of present about her work with an internship and this last few months. And so very excited to do that. And we welcome Rebecca, who's her professor and sort of advisor on the work. And Rebecca, we have a special treat. So one of our fellows, Mark Linzer, often sings songs and writes songs about the work that we're doing, Patient Revolution, and he hasn't been able to be here for the last couple of weeks because of work stuff, but he's here this morning. So we're going to kick off with Mark's going to do a song for us here at the beginning.
I was wondering what that thing under your arm was.
Yeah.
This is fantastic.
Yeah.
It's exactly what it is. Well, thank you, everybody. Zion, I'm sorry, I don't mean to interrupt, and thank you for the few moments of time. It's so nice to see you all again. And then I'll stay for a little while afterwards and then head into work. So thank you, Maggie, for my flexibility. I'll also mention that we have a Saturday night music ramble every Saturday at 9 o'clock Central Time, and I'll send Maggie the link. But if people ever want to come, just Zoom in and come sing with a bunch of us who play guitar and just have a very good time making music through this challenging time. So one of the songs, I couldn't decide between several songs for this morning. And so I decided I would do them all, but I'll just do a little bit of each. And so a little travelogue from the 60s. And one of them was a song that I sang in Switzerland when I biked through Switzerland with my bike on my back, with my guitar on my back. And I got to a youth hostel in the center of the country where everybody spoke German, but I didn't speak German, so I couldn't speak to anyone. So I sat in the bottom of the stairwell and played this song, and everybody gathered around this circular stairwell and started singing it. So you'll have to decide which of these songs they sang with me, and then you can sing with me too. You'll figure it out. I saw her today at the reception. Glass of wine in her hand. She was practiced at the art of deception. What it did was a bleeding man. You can't always get what you want. Could be a motto for our revolution. Can't always get what you want. You can't always get what you want. But if you try sometime, you might find you get what you need. Nazareth, I was feeling about half past dead. I just need some place where I can lay my head. Hey, mister, can you tell me where a man might find a bed? He just grinned, shook my hand, and that was all he said. Take a load off, Fanny. Take a load for free. Take a load off, Fanny. Right on me. Hey Jude, don't make it bad. Take a sad song and make it better. Remember to let her into your heart, then you can start to make it better. Places I remember all my life. Some have changed, some are better, some forgotten, some are gone, some remain. Now I know I'll never stop and think about them with lovers and friends. Still can recall some are bed and some are living. My life, I love you more. Yesterday, all my troubles seem so far away. Now it looks as though they're here to stay. Oh, I believe yesterday. Na, 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 na. Na, 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 na. Hey Jude. So this is what they all sang in Switzerland, all around the stairwell. Na, 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 na. Na, 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 hey Jude. Na, 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 na. Na, 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 na. Hey Jude.
Oh, beautiful, Mark. Such a lovely way to start the day, I have to say. Sets the tone for the whole thing.
Have a great day, everybody. Thank you for letting me sing.
Yeah, thank you, Mark. Excellent. Well, that was perfect. And Zion, the perfect introduction to your presentation, I think, sets the perfect mood. I'll let you take it over from here.
Hey, thank you. And thank you, Mark. That was like a wonderful mixtape. And I was really proud of myself for knowing all of the songs. All righty. Okay. Can everybody see? Great. Awesome. Okay, so good morning, everybody. Today I'm going to be giving a brief presentation on the Patient Revolution Playbook with a specific focus on the chapter, A Careful and Kind Approach to Social Determinants of Health. This is going to be a summary of work that's been done over the course of my internship. And then after, we'll have time for questions. And after that, we'll be going through some patient narratives to demonstrate how social determinants could be addressed at our clinic. Okay. So the Patient Revolution is a movement for careful and kind care. And as many of you might know, whenever you say careful and kind care, the first question you get is kind of like, what is careful and kind care? And I think that's a little different for everyone. But for me, careful and kind care is made up of these components. So it's composed of unhurried conversations and relationship building with clinic members, care team members, and community members. It's built on trust, and it involves using evidence-based practices. And a big part of that is humility and transparency, especially with just being honest about what you know and what you don't know when you're delivering care to people. And careful and kind care requires a lot of patience and understanding that all of this is a learning process. Oftentimes, I find that careful and kind care exists in contrast to what we find in present-day industrial healthcare. And I think the reason for this is that industrial healthcare has a business model where money and efficiency are a lot of times valued over people. And so it's hard to build relationships and have trust and transparency because, you know, we practice power hoarding and we have very strict hierarchies and very stringent protocols that ends up hurting people rather than protecting them. And then there's dehumanization on both sides for patients, but also for providers, where people don't really feel like they're being recognized within the system. And I think that when you bring up all of these harms in industrial healthcare, where you should kind of be getting met with humility. Unfortunately, you often get met with arrogance. So how we are going to bring careful and kind care to healthcare. We've decided that we're going to create our own demonstration clinic that exists outside of the constraints of industrial healthcare. So we're basically going to start from scratch and show that careful and kind care is realistic and can be an alternative to industrial healthcare. So to do this, we've been creating a playbook for the clinic. The playbook is going to exist as a living document that allows us to capture the process of creating this demonstration clinic. So it's going to grow with the clinic. It's a dynamic document. It's meant to capture our thought processes, our decision-making processes, and it's going to be a learning tool for not just ourselves, but for also anybody else who wants to learn about the demonstration clinic. So they'll be able to go back and learn from this entire design process rather than just being presented with the final product. And lastly, I think that the playbook is also going to be a great way for us to kind of remain accountable to our key values as we build the clinic out. So as I said earlier, this chapter that I worked on for the playbook was on social determinants of health. Social determinants of health are defined by Healthy People we're on 2030 now, as the conditions in the environments where people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risks. So social determinants are made up of 5 categories. First, there is your level of educational attainment and your access to high quality education. Then there's economic stability, which is really important because 1 in 10 people in the US live in poverty. We have social community and context, which is focused on people's relationships and interactions with families, friends, coworkers, and community members. Then there's neighborhood and built environment, and that's focused on a broad range of things, from violence to unsafe air to loud noises. And then finally, there's healthcare access and quality. And this is typically where clinics and health systems function, although increasingly we're shifting into trying to also have a positive impact on the other 4 categories, as we're starting to recognize that they have significant contributions and are oftentimes barriers to the overall health of patients. And social determinants of health are especially crucial to a careful and kind care model because they take into account all the non-clinical factors that affect a person's life. And so when we start to really understand these non-clinical factors, we can make sure that we're responding with care that doesn't further burden or harm patients. So the goal for this internship was to explore what a careful and kind approach to social determinants of health might look like. We wanted to explore what guidelines might be needed, where to set boundaries in terms of resources, what tools, behaviors, and skills might be helpful to a careful and kind approach to social determinants at our clinic. And to do this, I started by collecting information about how social determinants of health are currently integrated into clinics. I started by performing a baby literature review, meaning I developed a search strategy with the help of a Dartmouth librarian, Paige Scudder, and ran it on PubMed. And then I read peer-reviewed literature on social determinants in clinical settings. I paired this with gathering some qualitative information from clinicians about their experiences with social determinants in clinics. So I created a semi-structured interview guide, piloted it with a friend, and then interviewed 3 clinicians. And then in April, we started small group work and held weekly meetings to work on what social determinants of health might look like in our clinic. And we summarized the outputs of our weekly meetings and tracked our progress. So this is what that looked like to me with Maggie in the Cape and organizing all of our stuff. And then we all get to high five at the end. So for the literature, the good news is that the literature widely acknowledges that social determinants contribute significantly to health outcomes. And it was very clear that the general consensus is that health systems need to address social determinants of health. The stage that we seem to be at right now is establishing how to do that. The literature is widely focused on creating a screening and referral system process. So through this process, health systems are focusing their energy and resources on creating screening questionnaires that can be incorporated into electronic health records, where patients answer a bunch of questions. If they screen positive, then they're referred to community resources in order to address their social needs. And there are incentives and compliance regulations that support the use of these screening and referral processes. I also found that there were some other methods being looked at to tackle certain aspects of social determinants. Medical legal partnerships are being explored, and less commonly medical financial partnerships. Both of these are newer kind of understudied models. And as is common with like new ideas and concepts, research and interventions into best practices is pretty poor. So for example, screening tools rarely have any evidence for their ability to successfully detect patients in need or support these patients, and there doesn't seem to be any establishment of like patient measured outcomes or quality measures. And then qualitative information about patient and provider experiences using these tools is also pretty non-existent. So it seems that the industrial healthcare approach is doing really what it does best, which is searching for ways to standardize social determinants of health. So for example, this photo that I have here is like the use of ICD-10 codes to label social determinants in patients. And then, so I went from the literature over to trying to see, okay, what's actually happening in process by speaking with clinicians. And things seemed a little bit less promising than the literature would suggest. So when I talked with clinicians about the training that they received on social determinants, this is what one person had to say. And I thought that this was really important because conversations about social determinants of health are usually very sensitive, and they do take a lot of time to do well. And here's kind of a clinician just saying that when they don't have training in social determinants, and then, you know, even if they did, they don't have time. So then when I asked about how prepared clinicians might feel to address social determinants, the answer I got was really just reflective of this disconnect within the care team of not really understanding the roles of social workers and social workers not quite understanding the roles of clinicians, and then really just being like very disconnected in the work that they do, where they don't have enough, you know, trust and accountability to each other to be confident in the care that they're giving to patients. And then in a conversation about how helpful the tools for social determinants of health are, this was the response that I got. And this is really kind of reflective of the lack of evidence in the literature, because here we have a screening tool that's been determined to be successful, and yet it's never been used in context and it's never actually helped anybody. So how was that successful? So that's kind of the worry with creating these screening and referral processes. So with these findings and the ones in the literature, this really led us to the conclusion that social determinants of health shouldn't be treated as its own separate process within our clinic. It really needs to be integrated into the overall care that patients receive. So the challenge then became not to create a separate channel for social determinants of health. The challenge was then to create an approach to social determinants of health that is integrated into everyday care. So this became the focus of our April small group work. Now that we have that understanding that we want to incorporate social determinants of health into everyday overall care, we wanted to come up with tools, skills, and behaviors that might help us accomplish this. So one of the funny things from our small group work was that we need a new name for social determinants of health. So if you have one, throw it out there, so that we can easily communicate with patients about the subject. And then we also talked a lot about the care team, who it was going to be and what type of roles and skills we needed to be able to elicit social determinants of health information from patients. We decided that care team members should be really reflective of the backgrounds and experiences of patients that are going to be in our clinic. And we talked about soft skill training that care team members might do. So like compassion meditation, building empathy and resilience, how to build up patience and listening skills and be able to read body language and things like that. We also talked about what roles should be created within our new care team to support social determinants. So for example, having a community liaison or patient coordinator to be able to partner with community members and patients and better coordinate that process. For patients, we wanted to bring more autonomy to social determinants. So rather than imposing what we thought was important onto patients, we really wanted to give them space to prioritize their own social determinants of health and tell us what they felt was blocking their own health goals. We also wanted to give a lot of time to develop relationships to let these conversations happen naturally. And we also wanted to give space within the EHR for patients to be able to share updates on their own about social determinants of health. Within the community, we wanted the clinic to be a good neighbor. So we wanted to be able to really understand the community that we're in and its capacity to provide for itself. We wanted to end the cold referral system so that when a patient is accessing community resources, we get context and feedback about how they experienced those resources and how the community experienced delivering those resources. And ultimately, we wanted our relationships to help support community initiatives and to build community capacity in the long term. For the challenges and limitations sections of this work, as far as limitations go, I didn't really see any, and that's not because I think that this is a perfect process, but it's because the playbook is a living document and it's a learning document. So that gives us the advantage of if something doesn't work, that's actually perfectly fine because we're able to learn from it and adapt to it and change our processes to best fit patients and families and providers at the clinic. Challenges to this work, I think, were more personal. Anytime that you're kind of coming up with something new and there's no clear path, that's always just a fun, engaging challenge. So adjusting to that process in itself and adjusting to just going along with what the group is doing and having a looser form of meeting agendas and not having like a checklist of things we have to do was a big challenge. Challenging my own learned behaviors about what I think is necessary for a clinic to function and what has kind of just been conditioned for me to think is necessary was a big challenge. But the fellows are very helpful for that because you all come up with a lot of ideas that I might not have considered. And I think maybe the biggest challenge is just communication. So I am jokingly known as the person with like the hippie internship, which is fine. I enjoy my internship, but just communicating with people about like what the patient revolution is, what we're doing, why we're doing it, how we're doing it, is always like a workout for my brain, but hopefully I've done a good job with that today. And so sustainability, our next steps to cultivating care. The playbook is going to continue to be shared with the rest of the fellows and with other stakeholders, and we're going to get feedback and continue to flesh it out and build it up as we've been doing. As you all know, we are going to open a clinic. And then in conclusion, I really think that the clinic has an opportunity to rethink how social determinants are traditionally approached. I think other organizations have recognized the importance of social determinants, but they've had to fit their approach within an industrial healthcare model. So we're seeing the standardization of screening and like this one size fits all approach. And I think that our clinic can create a careful and kind approach to social determinants by having patients that feel safe sharing non-clinical information with us, by having a care team that has the skills to listen and respond to disclosed social determinants information, by having a no wrong door policy, which means that all a patient needs to do to get help for a social need is just share that with somebody on the care team. By having an electronic health record that gives context to stored information, and something that's adaptive and personal that patients can use to really tell us what's going on with them. And by building real genuine connections with community resources and making sure that we have feedback loops and shared goals. So I wanted to thank everyone here. Thank you to Maggie for being my mentor and guidance and leadership throughout this whole process. Thank you for Victor to writing the book. Thank you for having a class on the book to my professor, Paul Barr, where I met Maggie and Victor. And thanks for all the fellows for just participating this entire time through. Our weekly meetings are always a highlight. And then thank you to my entire teaching team. Rebecca, I know you're here, so thank you. And yeah, this is just a reminder from my friend Hobbs from Calvin and Hobbs. I really wanted to thank you guys all for just reminding me each week that, you know, like when you're frustrated and unsatisfied with the world around you, you always have the power to imagine something that's just a whole lot better. So that is all. Thanks, guys.
Fantastic. Wonderful presentation, Zion. Oh, so lovely. So we'll take a few minutes and I don't know if Rebecca, if you want to go first, or we can open it up broadly to questions.
Well, I first of all just have to say what a fantastically beautiful presentation, both visually and content-wise, Zion. So thank you. That was a pure delight. Started by that musical entree. It couldn't have been better. I love how you're challenging even just the naming of social determinants of health. I don't like determinants because it sounds so set in stone. And nothing of these factors is set in stone. And it is an entirely malleable process and to an extent, obviously, that we all are aware of with our reality of constraints in our society. But I loved that you challenged a different nomenclature and what would speak to patients. I would love your ideas. The first thing that popped into my mind was life circumstances, because everybody has circumstances that they have to deal with. But what do you see might be more patient facing in terms of identifying what these factors are?
Yeah, I don't know. I've been thinking about it for so long because I don't think it was me who brought up that patients might not know what social determinants of health are. And then because I'm like the MPH person, I'm like, what do you mean? There's a social determinants of health. Like it's obvious. So I think the challenge is like picking a name where all those 5 categories, you can bring that up. And so like, I think sometimes with like life circumstances, people might not think about like social connections. But then sometimes I think people usually go to like money and like access to healthcare as like their main ones, without maybe realizing like, do you have like a built environment around you that's good? Like, can you go ride your bike on the sidewalk, or is that not available to you? So just something that I guess captures a little bit of everything. And I don't really know what that would be. But I'm open to recommendations if anybody has a good one. I think life circumstances might be one of the better ones that we've tossed out so far.
I was putting a couple in the chat for you, Zion. hear from some of the work we're doing in Barcelona, but also in Singapore. So they Mapa de Vida, which is Life Map, is a tool used by social workers in a nursing home setting that we've come across that covers quite a few of these topics. And another one from Singapore is actually a tool that we've been working to develop around end-of-life care, which is a wheel of life. And again, it kind of pulls apart different aspects of life. So.
Thank you.
I love Mapa la Vida. That sounds so good.
Mapa de Vida, yeah.
Yeah.
Or things we should think about adding to the social determinants?
I had a question.
Mhm.
Actually, did you have a chance, or might you have a chance, to share what you learned through this process, but with social workers or people in the community health setting, and or patients? Because I think we kind of see, there was one slide where you talked about the disconnect between the social workers and HCPs in cross-referring, and how it sort of in no man's land, like nothing happens from there. So I wonder, what if we look at it through from the point of view of the community care team or from the patients, and what blocks, or how could we understand that no man's land a bit better?
Mhm. Yeah, I think definitely going forward, once we get past just the fellows, it's going to be presented to like patients and social workers, and I think anybody that's going to be on the care team. So I had talked with a couple of social workers kind of in passing about this, because I was using them to find out about soft skills, because they're the best for that. And I think that they were kind of sharing that they just are usually not considered as integrated into the care team. And so for our clinic, part of the care team model was having everybody, like do training together and understanding that everybody knows what everybody's roles are. And it's not something that's disconnected, where it's like, okay, the physicians do their training on this day, the social workers do their training on this day, the receptionists do their training on that day. And so by having it be like something where everyone is clearly together in like a team setting, and we do like weekly huddles where everybody shares out, important updates about patients and things like that. That's, I think, kind of our plan for overcoming that hurdle about people segmenting their work, and then segmenting patients. I think that's kind of how we want to overcome that and really focus on like a patient at the center and then all the team members around.
Madge.
Hi, this is Mark.
Oh, Mark, go ahead. No, go ahead, Mark, and then we'll go to Madge.
Thanks very much. It was wonderful. As an internist, I read something recently that the medical part is, 20% or something like that of sort of healthcare, and goes to how we define what we really mean by healthcare. But because I think it's sort of the 12 blind men parable describing an elephant, that we all think, yeah, this is what healthcare is, checking blood pressures and prescribing meds. But as you showed one of those slides, I thought, and I think that's what we're doing in this clinic. We've talked about it. We tend to, at least in our organization, the doctor is the head of this team, and then there's this team. It's like, that doesn't make sense at all. The doctor might be this little small part of the team. You've got most of this stuff, whatever you call it, social determinants of health, comprehensive health, whole health, careful and kind care. It has really nothing to do with the medical stuff, but you need that person as a consultant, much like some people that I see need transportation assistance, but we don't make the transportation department the head of the whole thing. It's kind of like should be a group leadership, and I know people have said the patient partnership, which I think is really lovely language that I've learned here. Anyway, that's just my 2 cents, and I really appreciate the opportunity to having spoken with you as well. Congratulations.
Thank you.
Thanks all, and kind of dovetailing a bit with Mark's remarks. Great presentation, Zion, just, perfect. I mean, my goodness, people are always looking for cogent ways to describe a lot of things that you did very, very well. So, I'm kind of registering all that. As I said in the chat, many people would benefit, will benefit and can benefit from your work. Part of your presentation makes me think a lot about financing and sort of what is the financial model that supports a way forward in the future. And I know somewhere down the line, there will be a policy, piece of imagination in the patient revolution thing. I know somebody who did some research, for instance, for the Robert Wood Johnson Foundation, and just looked at to what degree health systems are actually investing in supports or practices that would help in the area of social determinants of health. And it's all over the map, but mostly it's insufficient. And that speaks volumes, about sort of where we might be headed. It also, the thing that flew into my head, and you all will trust me and know what I mean by this, I was starting to think, yeah, let's defund healthcare. I mean, there's a certain way in which we have to also start pushing on, and that's certainly a concept I know that causes both alarm and opens up a lot of thinking as well. So thanks very much for stimulating a lot of these ideas. Thanks.
Yeah. I just wrote down defund healthcare. I think that's so funny. Imagining the article title. They want to defund healthcare. Great. I wonder how this.
I have a quick question or comment to make. I was really impressed with Zion's assignment for our course was to create an annotated bibliography for the work that they're doing in their internship sites. And the couple of articles from the VA that Zion found that talk about a role for social workers as narrators and writers of people's life story. And I found that profoundly interesting to think about how a patient, if they have the ability to communicate with a good writer who then can reflect back to them the story of their life to explain not only to themselves, but their loved ones, the situations that they're in, that give them also then the agency to own that story and move it out of a place of unhealth into health, I think is just amazingly powerful. I'm a molecular epidemiologist. I believe in oxytocin and everything it does good in terms of immunologic functioning. So it speaks to me to have that connection made, the story told. And I feel like it's a whole new line of healthcare work, which is a social worker trained and skilled, but also a writer who can narrate the story of a patient. And I thought that was brilliant. And I'm so grateful, Zion, for your deep digging into the literature to find interesting approaches like that to get to the heart of what matters in a patient-physician relationship. That was really impactful.
Awesome, thank you. Yeah, we were looking at just since we decided that we don't want to have a screening questionnaire, then the question just became, okay, well, like, how do we find out what are the social determinants of people's lives? So that was one of the ways that we were like, well, this could be a cool way for us to get to know patients. And then, as they tell their story, that's how, we can figure out like, oh, what was your education like? Where'd you grow up? People mention, what kind of food that their grandma made and what's important to them and those kinds of things. And going back to just patients having that autonomy to determine like what's important to them. I think the VA program did a really good job on that, where they weren't asking like a set questionnaire for the narrative program. It was just like, tell me about your life. And then each story was very different because people were able to just say what was relevant to them and, you know, their biggest moments in life.
Beautiful. Tina?
I echo the kudos. Great job, Zion. I had a question that might put you a bit on the spot, but you don't have to answer now either. But I wonder, as you were talking about all of this work and thinking, I also have been interested in this space, is that kind of the reaction that you get currently is, you know, to social determinants of health is an agreement from healthcare providers. Yes, they're very important. But then also this kind of, well, there's nothing we can do about those things, right? And I would love to kind of think about in, you know, 2 years, 5 years, 10 years, whatever the plan is, like, what is it that you'd like them to say about it? You know, like, what is the kind of, when you ask a provider, well, what about social determinants of health? It's kind of, I'd love to kind of hear, like, what would you like their answer to be? Because I think that, at least in some of the work that I'm doing, it's like the students in the healthcare field they understand, they value the importance, but they kind of already have this ingrained in them, like, I can't do anything about it. So what would you like their answer to be?
Yeah, definitely. I think I would like it to be like to the point where I think the confidence maybe that they have with you know, everything else in the clinical stuff, they also have with social determinants. Maybe, you know, like if you're treating with someone with diabetes, like you're not like, oh yeah, well, I don't have a cure for diabetes, so we're not going to do anything. Like kind of maybe that same approach where, you know, they know, like, okay, if somebody has food insecurity, like I can tailor my care plan to work around that. I don't have to solve food insecurity. That's a big ask, but I don't have to just, you know, do what I was going to do if this person had unlimited accesses to whatever food I wanted them to eat. Like I can, you know, maybe take extra steps. And I know that my care needs to be tailored around these social determinants if I want to provide the best care. But I don't think that the medical training curriculum really is set up like that. I know, at least for my friends that are in school right now, it's again, like it's its own course. It's like one little elective course and you learn about the social determinants, but like the rest of your clinical training is just like, this is what you do. And so because it's not integrated, then they're like, well, I don't know how to integrate. So I guess I would like to see maybe in 20 years, like that medical students are taught how to integrate so that it's not something they have to like learn how to do when they've already been fully trained for like 20 years. I think that would be like the perfect world.
That's great. Thank you.
Yeah. Lesh and last.
Kind of building on that, I love that question too. Tina, is there not enough evidence yet? Is that what you found, that we can make a case that addressing social determinants of health impacts healthcare outcome? So to answer the question of like, why should HCPs care about this?
I think there is an abundance of evidence that social determinants impact health. I think there is less evidence of how health systems can, like what they can actually do. So like evidence-based interventions. I think now people are just starting to do their interventions. But I don't know, sometimes when like there's a hot topic word, people just rush to interventions and kind of like forget all training. So like nobody's measuring anything, and like nobody's doing like peer-reviewed papers, and everyone's like, we do this over here, like this is what Mayo Clinic does, this is what Kaiser does, and then you're like, okay, well, how did you decide to do that, and how do you know it's working, and you know, what's your feedback systems? And none of that exists. and then I'm sure in 10 years, there will be a big like paper rush for everybody to say, guys, we didn't measure anything. And then that's like what always happens with everything in healthcare. So hopefully some people will watch this presentation and then say, well, our clinic will start measuring things from the start rather than as like a reactive 10 years later when we realize that we might have invested millions of dollars into something that we have no idea if it works or not.
Don't you think too, because you're right, there's an abundance of research out there that it's just part of the industrial healthcare system where because you don't get any sort of reimbursement for working on social determinants of health, and nobody wants to take responsibility for it. So even though, like in my mind too, I have an MD, just like, duh, it makes sense. Nobody's going to do something that doesn't bring in lots of profit. So why do it in their mindset?
Yeah, definitely. I think that's probably the best explanation of why everybody has like these screening tools, but nobody knows if they work because the intention is not really for them.
Mm-hmm.
The intention is just so that they can say that they have a screening tool and not get dinged for not having one.
Mm-hmm.
I would add that it's also because it's inside of a complex health system is a very expensive place to address these issues. So when we need reimbursement plus the support for all of the wasteful and sometimes needed infrastructure inside of a complex health system, which is the power of this clinic vision, is that we're pulling it out from a very expensive service delivery model. So it will cost less and require more simple resources, I think, to address pretty complex problems.
Maya?
Hi, Zion. That was great. I mean, what I think is kind of exciting is that, you know, your proposal of maybe some new measurements too for this, because I think one of the things you said earlier, which I thought was really key, is that we may not need to, the clinic may not have to fix or address the what the factor is that's happening, but could we shift things like, you know, we changed our assumptions, or we, you know, looked at care in a different way versus we treated the person, you know, we applied a different type of care to this person because we know where they came from and what's happening in the world that they're living in. And I think that's going to take different questions. It's going to take different outcomes. And it's not going to be, you know, maybe the things that people are writing papers on around social determinants of health. So it'd be curious for you, you know, if in your work, if you will maybe be able to point to some new places where we can see what are different outcomes or different measures that we can wrap around to know that we're shifting behaviors around these conditions or these factors.
Yeah. I usually think I jump straight to patient measured outcomes. And so I think for our clinic, that's going to be really crucial, but I think finding a balance between that. So I think currently patients don't get asked enough, like, how was your experience beyond like rate me on like a scale of 1 to 10. But then like the flip side of that is, you know, adding burden to patients and, you know, saying like, can you give me in-depth answers about what you liked and didn't like, and that taking a lot of time and effort and energy. But I think once we find that balance, that's going to be really key for understanding whether or not we're doing a good job with social determinants. Because I think that once patients know that this is a thing and that it's not just like personal behaviors that might be affecting their outcomes, once they know that there's all these other things outside of the clinic that are factors into their care and we explain that to them, then they'll know like whether or not we were conscious of that when we developed their care plans. And they'll be able to tell us like, well, I told you, you know, that my neighborhood's not good for walking and running, and you told me that I need to go out and exercise and I can't do that. Like, and people would get upset with that because they would say, like, I already told you this is a barrier and now you're not acknowledging that. So I think if we can kind of establish a way for patients to give us feedback on whether or not, like, we are helping them work around the barriers that they have in their own life, and whether they're satisfied, with the job they're doing, I think that'll happen over time, because I think if you just start asking somebody who's never been asked, like, what their opinion is, to tell you everything, they're baby steps. But I think after years, hopefully people will really feel comfortable just being vocal, and letting us know where we can do better. So I think patient measured outcomes are really going to be the key. And I think that they don't, in industrial healthcare, I don't think they get used that often because they're hard to develop and they're costly and they're time, like, they take a lot of time.
Yeah, I think that's really beautiful. We talk a lot about, I think social determinants of health is a great example where you can see that the way, once we recognized that it needed to be addressed, the way that we sort of developed an approach to building it was to look at what we could glean from research about what we knew about what was problematic, and then it was like designed from the very beginning to be at scale. So it was generic questions kind of asked in sort of a very specific way. And then it became about kind of screening those. And then it became about, okay, now we'll connect these to the things that are in the community. And I think kind of also to sort of Sheila's point about what we're creating by kind of pulling our clinic out of that system is that we can actually build it up from real world circumstances. And then as we gather the data from that, can start to imagine, okay, then how does that turn into tools that you can use, ways that you can measure? What are the patterns that we find in the stories rather than what are the patterns that we found in the numbers, in the sort of, data? And we've talked a lot about this idea that it's data and stories kind of interwoven is really the key to all of this, and that we have to find better ways to do that. And I think that clinic presents an opportunity to sort of build that collectively, everybody connected to the clinic from the ground up, and that will be exciting, I think. Yes, I think so. Yeah, I think the skills development part is huge, right? I think if we want patients to be partners, then we also have to invest in helping them have the skills that they feel they need to engage in their side. So I think that is a really critical part of all of this work. So anybody else?
I was just going to say, very similar to what you said, Maggie, is that measurement, we're so, because of how we're trained as clinicians and scientists, we're so focused on quantitizing everything. But when we're abstracting from the life stories and the context of which these things are happening, you lose something, going from this beautiful story to these quantized numbers. In shared decision making, we talk about the struggle of measuring that. And how it does become a tick box exercise. Did you do this or did you do this? And you lose some of that connection or that beauty that comes through the caring and kind, care that is shared between clinicians and patients. And so, measurement is difficult. And I think there does need to be, like you said, Maggie, kind of this balance between, sharing the stories and the actual numbers. And I think if the patients are truly partners and they're communicating in a trusting way with their clinicians, what's going well and what's not going well should become apparent through those stories. And if those stories are shared amongst the care team, those can be used for improvement. But I think it's this comfort with not necessarily having 50% of patients say that they would rate us an 8 out of 10, kind of stuff. I feel that we need to get a little bit more comfort in using those non-quantitative measures.
Well, I would add also not to lose sight of the end game. So we're going to measure ourselves and the clinic and the processes and the number of stories we hear, et cetera, and all of our work with patients and their families in partnership, and feel good about accomplishing things, but to be figuring out a way to be constantly checking in with the patient and their family about what is the end game here. As you have an 85-year-old woman sitting in front of you, what does she want out of this? And how are we validating with her that she's achieving her health and wellness goals in her life outside of our clinic setting, outside of her diabetes management or her whatever. So there's sort of process measures that will be all about how the clinic runs, but there are also outcome measures that say, hey, have we actually hit the mark for you and your family in your well-being?
Yeah, that's great. I don't know, are there any community reported outcome measures? Does anybody know if, Sheila, do you happen to know if there's anything there? No.
I don't know. It's a really great concept though.
Yeah, no, I think it would be interesting to do some research on that. Yeah. Yes, great point, Greg. Yeah, I think that's kind of key to this whole thing, right? Is creating a more equitable environment where and recognize we have to build that over time. There's a lot of rituals and history in medicine that will inform everyone's behavior, and this was partly where it was so beautiful that Zion highlighted it, but also it's been one of the big things that I took out of our small group work was just the overwhelming importance of bringing humility to every interaction, every idea that we have, to really be open to understanding if it's helping us kind of achieve what we're trying to do, and to keep a watchful eye for paternalism or industrial healthcare practices kind of creeping back into the way that we're doing things because they're comfortable and we've seen them work before potentially. So all very exciting.
One quick comment, and I sense we need to kind of move on, but I just wanted to say, so much it's so interesting sometimes when you start talking about healthcare with people who are not involved in the belly of the monster and are just trying to have a solid visit with a practitioner and have needs met and whatever. And what often occurs to me is that in some people really, that is what they want. They just want a good interaction that meets goals and that isn't too time consuming on their lives as well, nor too burdensome. And in some sense, a lot of what has to go on in this inclusion piece of this is in some ways, healthcare, fix thyself, and don't burden patients and families anew, in our need to know and, how is your experience in this and that? I mean, we sort of know, and I hope that I'm not trying to say this in the extreme, we know so much. I think that a lot of it is really how to put all kinds of ideas into action. So just a thought.
So I'll just say thank you, first of all, Maggie, and all of you for providing such an inspiring, welcoming, caring learning environment for Zion as an intern, but also then Zion for you to take the bold move to reach out for an independently self-sourced internship. What a fantastic connection for all of us to be able to learn from you in this work. So thank you so much.
Excellent. Fantastic. Well, Zion, I know you had the narratives too, but maybe we'll just record maybe you and I can just record the narratives separately and we'll be able to put those up later. Yeah, okay. This was a fantastic conversation. Like I said, we'll get this posted. We'll find a place for it to be so you can share it with other people, because I think it was both the presentation itself was incredibly inspiring, and then the conversation that we had after I thought was really lovely as well. So thank you, Zion, for joining us. I hope Zion has said that she's gonna maybe continue to hang out with us. Might not be quite spend quite as much of her time with us as she has this past 8 weeks or so, but hopefully she's not going to drop off as totally as a fellow, and she'll still pop in and help us shape the clinic. So, which is very inspiring, I think, for the work. And yeah, thank you all for taking the time this morning. I really, really appreciate it. And we'll see you at the next one. Thank you for joining, Rebecca.
Everybody.